An adult male prairie falcon arrived at the Rocky Mountain Raptor program after being rescued from an enclosure surrounded by barbed wire. The falcon exhibited good body condition, but examination of the right wing revealed swollen and bruised tissue overlying a closed fracture of the major and minor metacarpal bones. 2 lacerations on the leading edge of the wing caused the propatagial tendon to become visible. The wound was cleaned and covered. The fracture was stabilized by means of a figure 8 wing wrap. Medication included florfenicol, an antibiotic, for 10 days, and ketoprofen, an anti-inflammatory medication, for 3 days. The injuries healed without complication. By day 16, the fracture had stabilized and the bandage was removed. Passive range of motion restored the range of extension of the shoulder, elbow, and carpometacarpal joints. By day 30, the falcon was moved from an indoor confinement cage to a small outdoor recovery cage. Joint attitude and range of motion were normal, and the falcon exhibited full wing extension capacity. On day 35, 2 presumably self-inflicted wounds appeared along the tendon of the right proximal patagium. The wounds were ulcerated and crusted, but the propatagial tendon was intact. By day 37, the wounds had begun healing, but several excoriations and puncture wounds were now evident along the right patagium. Over the next 4 days, as wound care and bandage changes continued, no further mutilation was seen until a worker at the center observed the falcon chewing on the patagium of the right wing following bandage removal. The falcon presented to the CSU, Center for Comparative and Integrative Pain Medicine, 47 days after the initial injury. Treatment to address the self-traumatization wounds included ketamine, gabapentin, and low-level laser therapy. Over the next 5 days, occasional chewing at the right patagium was observed, the wound healing continued, and skin closure was complete by day 52. However, once again, new wounds appeared on days 53 and 60, accompanied by considerable inflammation. This cycle continued on until day 83, when the rehabilitation center staff considered euthanasia because the bird continued to self-mutilate. If he succeeded in tearing the propatagial tendon, his ability to fly would cease. This required a rethinking of his pain medicine intervention, and the decision was made to perform a regional nerve block involving the radial and medial-ulnar nerves. A nerve locator determined the position of these nerves in the wing by provoking wing twitching in response to gentle electrical stimulation. Local anesthetics were instilled around the nerves. Soon after recovery, a temporary wing drop was noted, suggesting a successful neuromuscular blockade. This reversed within 2 hours of the procedure. The dose of low-level laser therapy was increased in terms of joules per centimeter square delivered and with a longer wavelength of light. Ketamine was given more frequently, and the dose of gabapentin was elevated. After this intervention, no further attempts at self-mutilation were observed, and no further wounds developed. 10 days after the interventional regional analgesia procedure, the wing was left unbandaged. Wounds were fully healed by day 109, and the pain medications of ketoprofen, ketamine, and gabapentin were gradually discontinued by day 125. After flight cage testing for stamina and trial hunting for mice, the falcon was released successfully, 181 days after presentation. This case report, published in 2009 in the Journal of Avian Medicine and Surgery, is one of the first descriptions of treating neuropathic pain in birds. It demonstrates how information derived from studies in mammals can serve as guidelines for multimodal pain management in avian species. A multimodal pain medicine approach such as this allows clinicians to avoid the undesirable effects of drugs at higher dosages. In addition, more complete and effective analgesia may be obtained by targeting numerous pain-producing and pain-alleviating pathways. Appropriate treatment of this pathologic neuropathic pain problem allowed for the bird's full return to function and release back to the wild.
And it took a lot of work by a lot of people to get him healed up. And he also had to have the will to survive. And that's just fantastic. Well, I have to thank you and Narda and everyone else there.
Bonnie did the injection.
It was interesting because twice a day for so long, it was amazing. And that's the kind of bird that, I mean, he was a pistol every step of the way. And he was so close to just completely cutting through the septal tendon. But one thing we've learned, even if the wound is close to the tendon, we can't give up because we have a blend of things.
That's what it
The
takes.
laser light therapy.
Yeah. That's what it takes with other species with neuropathic pain. It's really effective.
When Gail said we were going to start this low-level laser therapy, I'm like, okay. And then when she told me what we needed, I'm like, you mean just a laser point? Laser point. Amazed at the immediate effect it has.
Mm-hmm.
You pull a bird out of the cage and it's raw and it's red, and you do the therapy, and it's like, no, that can't be right.
I know. I've had that same statement that I said to myself.
You can't. It can't start healing that quickly.
I know.
But it does.
Yeah.
It actually does. And when and Amanda was there for a lot of these sessions, is that when we do give him his injections, do everything else, and we start the laser therapy on him, he'd basically fall asleep.
Yeah.
He would completely relax. And that was unlike him.
Yeah.
And it was amazing. It did the trick. It obviously relieved at that point what was bothering him. But
That's very
it really, really is impressive. And we continue to use the therapy in those appropriate situations.
So let me know. Yeah.
So it's now it's not so much a leap of faith anymore.
Yeah.